4 years. This is the 5th year is going to be, which is earlier it was, we used to follow it as a Retinnova session, and as because there may be a little bit of similar, this is a very unique session where some kind of a innovative retinal videos, any kind of retinal video or innovative case presentation which is being shown, followed by the discussion and the dissection by the key opinion leaders. For this time, we are slightly changing the names from Retinos to Retinnova. So this is an innovative retinal session. From now onwards, this session will be called as a Retinnova. And for that, I would like to call our key opinion leaders, Dr. Mahesh P. Shanmugam, sir. Please be on the chair. Dr. Pramod Vende, sir. Please be on chair. Dr. R. Kim, sir. Please be on chair. And Dr. Lalit Verma will be joining us shortly. So we'll wait for, we'll start the session and we'll wait for his joining. And we have our key opinion leaders here, followed by our innovators. I would, just, I'll just declare the names: Dr. Himadri Chaudhary, Dr. Aditya Kelkar, Dr. Sunil, Dr. Manavi Sindal, Dr. Sangeet Mittal, Dr. Unni Krishnan Nair, Dr. Devdulal Chakraborty, Dr. Chetra Jaidev, and Dr. Subhendu Bodal. Because there is a little bit of change of the sequence, Sunil has to catch the flight. So Dr. Sunil, will invite Dr. Sunil as a first presenter. Dr. Sunil, please.
Okay. Good evening, everyone. Let me present to you a case of a trauma case. It's a corneal tear case with an unusual foreign body. Let's see what is this unusual foreign body. 40-year-old male patient presented with a corneal perforation. There's a large cloud nail impacted in his left eye. There was an history of using soft contact lenses. His other eye visual acuity was 6.6. This eye had an hand motion vision left eye. There was a total eye edema with a large horizontal corneal laceration, limbus to limbus, at the inferior one-third of the cornea without any scleral involvement. Since we're suspecting a foreign body, CT orbit showed no signs of an intraocular foreign body. Patient underwent a primary corneal tear repair under general anesthesia. Corneal perforation was closed with 10-0 nylon, and the post-traumatic aniridia was seen. The crystalline lens was intact, remarkably clear, but showed inferior zonal lysis of about 4 clock hours. The soft contact lenses worn at the time of trauma was not retrieved during surgery. The surgeon who performed the primary repair believed that the soft contact lens had fallen off. For the following days, B-scan monitoring of the posterior segment showed a small posterior perforation site with a vitreous hemorrhage, but no retinal detachment or intraocular foreign body was noted. 7 days after the primary closure, pars plana vitrectomy was performed to remove the vitreous hemorrhage to explore the posterior segment. At this time, the visual acuity was counting fingers. After vitreous hemorrhage removal and thorough vitrectomy, this was what was found. A contact lens inside the eye in the vitreous cavity. Now the challenge is how to remove it in toto and without leaving behind any pieces of the soft contact lenses. It has gone through the inferior zonular deficiency which patient had at around 4 to 6 clock hours inferior deficiency. The best would be to stain these contact lenses, which gives it the overall, even if you cut it into the pieces, bimanually you can tear it off and cut it with the cutters. Staining is the main key here, because staining allows you to see the fragments or the whatever even you can't be behind even the small pieces of the soft contact lenses if you stain the contact lenses. So once you've done that, you can easily eat away with that cutter. But the key thing I wanted to highlight here is sometimes you can encounter surprises in many ways, and not to leave behind any fragments of the soft contact lens, even though it's an inert material, but needs to be removed. And the staining helped us in total or complete removal of the soft contact lenses in this patient. Okay. So the soft contact lens was stained with trypan blue dye. The contact lens bimanually torn, and the rest of the procedure is same, and the vitrectomy was completed. Take-home message is staining of soft contact lens proved as an indispensable to ensure the complete removal of all pieces, since the use of vitreous cutter created a small contact lens segments or fragments which would have been left behind if it would have been not stained in advance. Thank you.
Important question is that was there any need to remove? Number one. Suppose if we clear the vitreous, Sunil, and keep it inside, so there can be a significant change once it comes in front of the macula, then the vision becomes clear. So once they lie down, they becomes clear. And if you don't remove it, so there will be always a fluctuation of, the vision.
Patient's wife may complain. Some days she's looking beautiful, some days she's not looking beautiful.
Okay, so what can be the even wiser way of taking it out?
You can't leave it as in a mobile piece running around inside the eyeball. I don't think that's safer. Besides the point what Dr. Mahesh was mentioning.
Okay.
But the other thing is, instead of breaking it into pieces, you could have brought it out through the anterior route, right?
Lens was clear, sir.
Clear lens was
clear
there.
lens except the zonal dialysis was there.
Okay. I mean, you still could have, anyway the lens, if it is phacodonosis is there, why not remove the lens? And how old was the patient?
45, sir, 45.
All the more the reason to remove the lens, remove this, and put an SF5 oil or secondary oil over there.
Okay. So that was probably another way out, easy way out, and put the SF5 oil. So what I was thinking of, Dr. Shubhendu Bodal is here. So Dr. Arup Bhaumik has a kind of a removal, IOL removal thing. So if you go there inside and you can just tag it with this, and then you can just pull it inside. So they have a tube like, so that like the IOL goes in, the similar it comes out through that tube. So similar way. No, can that be protruding into the vitreous cavity? Is it possible? No. So unless until if it comes in the anterior chamber, then it is easily can come out.
See, you can't roll IOL in the vitreous cavity single-handedly like that. What you're saying, I understand rolled IOL, but it's not that easy because it has to be positioned for to roll.
Yeah.
Here the question does not arise whether IOL to be removed or not. You are going already inside, you are having a vitrectomy done, there's no question of there's no second thought for that. It has to come out.
No, I think we can think about it. We can probably make a sclerotomy larger and then put a larger bore on through which you can put the forceps and hold it and remove it. But when it is coming out with a cutter, why do all this? Because you don't have to increase the size of the sclerotomy. So what Sunil did was elegant. It was able to cut with the cutter. Then why do you want to enlarge the sclerotomy and make more complications? So if you are able to cut it with the cutter, I think that's the best way to go about it.
How easy was to cut it?
It was very easy to cut it. It's a very soft contact lens.
Then all the problem is solved with that only. So, but this is an unique kind of foreign body which we usually don't come across for any, and it was not expected also.
It was not.
Except for the fact that staining part, yes, like Sunil says, it can stain it. Other way is to hold it with one forceps and then cut it with the cutter on the other side so that you're not losing it, and then just like how you would start from one side of the force the contact lens and cut it off. I think that may be also there. Staining, yes, plus minus. I have no idea with staining.
Sure.
I don't think anybody will report it, this thing.
Yeah. So, thank you. Thank you, Dr. Sunil.
Change.
That's another thing you can do. You can probably cut it into 4 and then remove it to the sclerotomy also.
Yeah. Thank you, Dr. Sunil. It's a unique case, and we would request Dr. Manavi to present her case now.
Good evening, and since you had requested me to come up with an innovation, so I have come with an innovation that we had made. And for lack of time, I'm going to skip to the video. And can we have audio for this, please?
In the this video, we demonstrate the process involved in making the RetiSurg model using three-dimensional printing. This model is beneficial in training the novice surgeons for vitreoretinal surgery. We decided to utilize this technology to create a model eye for practicing the basic steps of vitreoretinal surgeries. How is the model eye made? An anatomically accurate sketch of the eyeball with appropriate dimensions is incorporated into the CAD software. This software converts the native file into an STL file, which contains the information for manufacturing process, including the material and dimensions of the object. STL file is sliced into a G-coded file, which is then transferred into the 3D printer to create the model eye. The model eye consists of two interlocking hemispheres. The upper one is made up of flexible material, that is thermoplastic polyurethane, and the lower one is made up of polylactic acid. Preparation of the retinal film. A colored fundus image is printed on a regular white A4 sheet and folded into a hemisphere using the concept of K-comb wrapping. A 3D printed tracer is then used to customize the fundus printout so that it fits perfectly into the lower hemisphere of the model eye. Alternatively, a PETG sheet with printed disc and retinal vessels shaped using thermoforming technology can also be used. This film gives a realistic fundus appearance. Assembling RetiSurg. A cardboard box with a hole in the center is used to fix a microscope handle cover. The model eye is placed over this assembly to achieve a stable base for surgical practice. Two ports which simulate the superior sclerotomies are fashioned in the upper hemisphere of the model eye using the routine trocar cannula sets. This assembly is then used in conjunction with the operating microscope along with a wide-angle viewing system to visualize the retinal film in a simulated surgical scenario to practice various steps of vitreoretinal surgery. RetiSurg can be used to comprehend the XY movement of the microscope with an endoilluminator, maintaining view of the desired retinal locus with no instrument glare can be practiced as a precursor to actual vitrectomy. The model enables training the use of non-dominant hand to achieve the desired flexibility required to perform bimanual maneuvers during vitreoretinal surgeries. Endolaser photocoagulation can be practiced on this PETG sheet, which gives a very realistic feel. Use of the RetiSurg for initial training helps develop an intraocular spatial sense of the instrument position with maintaining steady focus of the retina. This can aid in ease of operating on a patient and minimizing complications related to retinal touch. Sterilization by ethylene oxide and absence of any organic material make RetiSurg.
So that is about this model eye, which can be used for some basic training of fellows, like hand-eye coordination, comprehending the X and Y movement, manipulating instruments. And if you have the PETG sheet, you can also practice endolaser photocoagulation. Much cheaper alternative than the extremely fantastic VR-based machines which are available and is there also right now in the biomedic stall. No, the sophisticated simulators are available at the biomedic stall. This is a very simple version of that.
So what is there in the, this is a nice innovation, really nice innovation.
Manavi, what is the material that's used as a vitreous material? What do you use
No, there
inside?
is no vitreous, sir. If you want, we can put visco and practice with it.
No, because we tried it, the Retia is the same.
Yeah.
That Aurolab makes, it's got a film in it. Except that the upper part is not a flexible material.
Yes.
But we still made holes and we're able to. But what is important to get the real feel is to have the actual vitreous like gel, which we are not able to find equivalent material to that. white of the egg is, that's...
Probably,
I
but you
haven't
can't
tried
take it
using
into
that.
your OT. You can't take it in. You take it into your OT at the end of the day, probably.
When you are going to use it in the wet lab only,
Yeah.
not inside the OT, right? Yeah.
Sterile.
Yeah, you're eating it, so it's as sterile as...
It
Yeah,
is
that's what I'm
sterile.
saying.
Yeah, even the raw egg is sterile inside. Yeah.
Yeah.
What is the lens on the surface acting at the
No,
cornea?
nothing. So it's direct visualization kind.
Then why would you need a wide angle?
Wide angle just to get the grasp of it. You can see through that also. Directly also you can see.
But you can put a lens over it, no? Like a contact lens you can put on
Yeah,
it.
probably we can try that in a modification.
Correct.
Yeah. We, okay.
Table tennis balls. It was done to teach indirect ophthalmoscopy, and of course the inside half was painted.
Yeah.
And the whole thing was put in a mask available, so it gave a realistic feeling.
Yeah.
The contact lens will
remove that, yeah.
concept
So
of-
we had done a table tennis ball which we were cutting in a half and sticking either a carbon sheet or a printed mock this thing and using it for laser practice.
When I did this,
Also.
thermocol was not available, but now thermocol also is there, so fixing it is quite easy.
Yeah.
I liked your method of getting
Yeah.
the retina fundus inside. It's fine. But that white of the egg, I'm very sure it will work.
Good suggestion, sir. Thank you.
Thank you.
Yeah, thank you. Thank you, Dr. Manavi. Actually, this is a good innovation so that which is for wet lab, this is very, very easy to do it of. We'll move on to our next presentation, Dr. Chaitra, please.
Thanks, Rupak. I'll be speaking on three atypical CNVMs. So should I finish all three and then we have, or should we do it case-wise? All three. All three, okay. So this is the first case, young female in her 30s. She came with blurred vision in the left eye since a week, 6/18 vision. No significant past history, no trauma, not even gone for an eye checkup before. On examination, IOP is normal, no intraocular inflammation. So this was the presentation she came with. And even at this point when we saw her, we asked her, has she undergone some sort of trauma in her childhood? She said not at all, never been to an ophthalmologist. But we were wondering now if this has been long-standing, as it appears, what was the cause for a decreased vision. And here you can see some sort of fuzziness at the fovea. You see a yellowish lesion. And then when we see the OCT, you can see at the edge of the self-settled retinal detachment, you see a CNVM here. So we went ahead and we gave her an injection. So this is pre-injection and this is a month post-injection. Of course, she's doing very well. But the question was, why did she develop it? There was no inflammation. Is it, if it's trauma, why so late in the day? And what was the potential cause? Is it just an idiopathic CNVM overlapping with a self-settled retinal detachment? So we couldn't really find the pathology here, but the response was pretty good to treatment. So this is another case, teenager presenting with blurred vision in the left eye for 10 months, had not come for various reasons. Vision in the right eye was good, vision in the left eye was 636. Both eyes had extensive areas of chororetinal atrophy. Prominent underlying large choroidal vessels were seen. So this is the picture. Again, here you see on the left eye, there's something going on there at the fovea. This is on the multicolor imaging, and this is the optos and the OCT. Again, you see CNVM there. This is in a patient with choroideremia. Again, never been reported before. And etiopathogenesis, since both eyes has choroideremia, what could be the one that is causing the CNVM in the left eye and everything else okay in the right eye? Again, this patient went ahead. We saw the membrane. We treated the patient. This is the Solix image, wide field octa here. And you can see post-treatment, not great response, but at least some reduction in the intraretinal fluid. The patient is still on follow-up with us. Their vision had improved to 6/18 post-injection. Third case, 76-year-old female. She came for cataract screening. Vision in the right eye was 6/15 and in the left eye was normal. She was largely asymptomatic, but when we did the OCT, this is what we found. So this point of time, we told her, we may need to investigate her further. Other than the PEDs there, you can also see this was the only radial scan which had this defect, full thickness defect. In none of the other scans was there a full thickness defect like this. So she came a month later. vision had not changed too much when this is how she presented. At this point of time, we got a little worried because this was in a month it progressed so much. We even, because of the intraretinal fluid there, a little difference in the PED height as well. We wanted to also do an angio to see if something was going on. She was not very keen. Patient is actually from Kolkata and currently being managed by Dr. Anirudh because she came back here. So I went ahead and did an octa and we saw a neovascular complex there. So this was overlapping with a macular hole. We gave her an injection. She felt a little better after the injection, but eventually I had to advise her surgery for the macular hole because it was increasing quite rapidly. So this is post the macular hole surgery. Vision was pretty good. And subsequently, she did not come. This was in April 2023. She seemed to be doing well. She didn't come back. The next she came was this January. And again, she's come back with a recurrence of fluid there. And here my worry was, what if the macular hole opens up because of that, fluid there? I was not very sure. So she went ahead with another injection. She was there for follow-up till Jan end. And then now she's in Kolkata. And from what I hear, she's received 2 more injections for the CNVM. So those were my cases. I mean, rather unusual presentation. I just wanted to ask if there is any way we could have done better in any of them or some sort of thought process on the etiopathogenesis. Or are they just coincidences? One with choroideremia, one with a self-settled RD and one with a macular hole.
In your second cases of choroideremia, if you just show this, response picture.
Yes.
Yeah, this one. So the subfoveal choroidal thickness is quite significant here.
Yes.
Isn't it?
Yes, it is.
So what do you expect in case of choroideremia in subfoveal choroidal area?
I will even show you the other eye actually. See, both of them had a similar picture.
So do we expect more of a myopic eyes or a leptochoroid kind of picture or so much of pachychoroid like a picture, sir?
I really haven't done OCT to show what exactly happens in choroideremia, but of course there is a thickening of the choroidal layer here. Mm-hmm. You are not expected to have a thickened choroidal layer in a choroideremia. It should be thinner. So, and this is not a classic choroideremia in that sense, and the patient is very young, isn't it?
Yes, sir.
Yeah, so
very
it's
young.
probably an evolving disease is what I would think. But is there any, she's a myope, is it?
Yeah, what is refractive condition?
I'm not very sure actually. I haven't put in the refraction. I don't remember. I don't think he's a myope.
But on what basis did we make a diagnosis of choroideremia?
So because of the fundus picture itself.
Because this is not classic choroideremia appearance because more of nasal changes are there and then patches are there. But of course, I don't know how choroideremia appears in a teenager age. Yes, that's also there.
So, but this didn't fit in anything else. In fact, we've asked for genetic testing also in this particular patient. He said...
I think an electrodiagnostic test would have been...
Also didn't pick up anything significant.
The EEG is normal or... I wouldn't expect it to be normal because in the right eye, if you see, there is one area of spared foveal RPE. Surrounded by that, there is an area of atrophy. Because the fovea is kind of spared in the right eye. Left eye, of course, there is something else going on. So I'm not too sure if this patient has choroideremia or if and that's a mid-peripheral pigmentary changes. I don't know if the visual fields would have been done and electrodiagnostic
so both electrophysiological testing and genetic testing is still pending. He has not got that.
And also visual fields probably because I don't know if there's a history of night blindness.
I haven't done that.
I think these things would have to be done before we conclude that this patient has choroideremia.
Yeah. But what else could it be, sir? If it's not choroideremia, what else can it be? Nothing, sir. No history at all. Nothing. He just came, and this was a 10-month history.
How old is the patient?
Sir?
How old was the patient?
16, sir.
No family history of night blindness?
Nothing, sir. No, pedigree was normal. And because he's in his 10th standard, his follow-up is not very great. So after the first injection, he's yet to come back. We called him back, nothing after that.
No, and there is some pigmentation you can see
yes, sir,
in so I would really rule out a hereditary degeneration.
Yes, we'll call him back and we'll do
I think rather before we call this patient as choroideremia.
Especially the blood vessels also
looks narrowed. Yeah, the blood vessels are also attenuated. That's one other thing.
No, but here, sir, if you look at the outer retina extrafoveal, there's so much of
No, there's photoreceptor atrophy. That's corresponding to that area of RP atrophy. As I mentioned, in the center of the fovea, you see one area of RP is pad. Just beyond that, you see RP atrophy, which is what probably is what you're seeing there also.
Yes.
So I would probably look at revisit the diagnosis of choroideremia in this patient.
Okay. But then the CNVM, there's no other way.
CNVM can happen in any of the other heredomacular degeneration as well. That can be, but I'm not sure if this is choroideremia.
Okay. That too, I will redo the tests. I mean, I've advised him, but once he comes back, maybe the electrophysiology and fields at least.
Sure. Your case number 1, can we go to the OCT prior to the one here? Yes. Of course, that's a spontaneous reattachment of the retina. Why a CNVM happened, it's very difficult to say. This is the first OCT, right?
Yes, sir, pre-treatment.
Of course.
These are the pre-treatment OCTs.
So had a break in the Brooks membrane somewhere.
Yeah, that was actually the question. How the pathogenesis of that, it does not look like a scar. It's a post-inflammatory CNVM is also different, they behave.
There was no inflammation at all.
Yeah. This is a post-inflammatory, the reattachment, spontaneous reattachment of the retina. If you go back to the color photograph.
So it is at a junction of the normal and the detached retina.
Exactly there.
So this is probably, can it be just because the RP atrophy is lying into that area. So probably the Brooks membrane is weakest at that area. So this is the junction of the normal Brooks membrane and the weak Brooks membrane. So the whatever has started popping up through that area, probably
that's what I've shown in the arrow as well. That's the junction.
That's the logic. But the issue is why aren't we seeing more of this in patients with spontaneously reattached retina? That was the counter logic I was thinking in my head. Okay, fine. Because we know that in patients with RP, the patients with choroidal folds, there are papers where you have choroidal folds, at the apex of the choroidal fold, you have RP atrophy and a CNVM can form, or a CSC kind of a leakage can happen. So that is the logic. But then if this is the pathogenesis, why aren't we seeing more of CNVMs in patients with spontaneously reattached retina?
So you've seen some, sir?
Have you also seen? I have not seen one as well. So that is the counter logic I was having in my head when I thought, okay, this is fine. You can explain it this way, but why aren't we seeing more of this? I can't explain.
No idea.
And the last case, to the fovea, maybe.
Possibly, that's also there.
The last one.
Last one, I have seen some of these. AMD with the macular hole, I have seen some of these. I have seen macular hole with PFT CNVM. And in one of those, actually, I've gone through the macular hole and removed the CNVM and then...
Very adventurous.
This is a type 1 CNVM, so you can't remove this. This is a type 1 CNVM.
Yes.
Here you can't remove. So I
would
would
the macular hole open? Do you think there's a risk here? Because if you see in this, there's a slight splitting there.
Correct. But then you relieve the tangential traction, so the chance of it opening, yes, it can open, and then probably anti-VEGF and anti-inflammatory agents may make it close again. So that's probably for your next Retinnova, I think.
I hope.
You've not operated on this, have you?
I have, sir.
Oh, you did?
Yeah,
Okay. That's how it's closed. Okay.
She came back to 6'9", but then the CNVM recurred. Thank you so much.
Thank you, Dr. Chaitra.
Our next innovator is Dr. Aditya Kelkar.
Thank you, Rupak, for having me in this exciting session of Retinnova. So I'll be talking about a patient who was operated previously for diabetic TRD. And after his initial surgery...
This is Amsler charting or what? Correct.
So after the initial surgery where we had done phaco-vitrectomy with silicone oil,
you're not seeing
I'm
any...
seeing some different slides here. Okay. Okay, so 1 month later, after the oil was removed, this is how the patient presented. He has two large holes, many large holes, including the one in the center of the retina. So the task was to manage this patient who also has a macular detachment, obviously because there is a fluid now on the posterior pole. So the idea was to plug this macular hole and peel off the membranes, and therefore we had to use something different because there's no retina left. Autologous retinal graft is not possible here. So we went ahead and operated this patient, clearing up the vitreous hemorrhage. After the fluid air exchange, I drained the subretinal fluid from the peripheral break, stained the membranes with Reti blue dye. So peeled off all the possible membranes from everywhere. Tried to stain the internal limiting membrane, there was hardly anything there. There's a small band there, you can see, still maintaining the traction, so I used the diamond dusted membrane scraper to peel that membrane, lift the edge and then removed it with the forceps. I used purposely a large amniotic membrane graft, almost about, you can say, 4 millimeters or 5 millimeters in size, almost covering the entire posterior pole. Made a enlarged the sclerotomy here because putting this large sheet of amniotic membrane graft was otherwise impossible. Under PFCL, this flap was placed on the macular hole and the area surrounding it. And then the endolaser was performed on the rest of the retina. So you may be wondering what is the point, because now this is completely blocking the macula. The rest of the retina is already scarred by laser. But you will see why I used this large amniotic membrane graft in the next slide. So after the endolaser, this was followed by silicone oil injection. You can see the graft is in place. This is the initial picture, 1 week. Graft is covering the macular hole, but the macular hole is not closed. And there's a huge amniotic membrane graft almost covering arcade to arcade. And these are his subsequent images from 1 month to 4 months, and you can see a crumpled up amniotic membrane graft lying in the corner. And now the patient's vision has improved from counting fingers to approximately 1.5 to 2 meters. And this is the kind of appearance that you have. There is a type 2 closure. As you can see, the retinal edges are opposed, and amniotic membrane graft has probably done its job and is now lying in the corner. Thank you.
I like Aditya's positive energy, because that wouldn't be the music playing in my ear if I have a case like that. Some comments, of course, very beautifully done surgery, except that these are cases which the retina tears very, very easily. So, and you had put a put a chandelier. So these membranes I would usually dissect bimanually. Unfortunately, it didn't bleed, because the reproliferation in a diabetic, they bleed very, very badly. So these are the patients I would probably dissect bimanually, remove the membranes. I have put amniotic, but 4-5 years back. And if you see the original original presentation many years back, I think 10-12 years back, was by Samina in Retinnova. She had actually put the amniotic under the hole, so fairly large ones, and they persist for years together. Actually, for a year and a half, it persisted, and then, of course, you don't have a too great improvement in vision, somewhat the hole closes. So here, I would have probably, there are 2 ways to go about it. Either way, you wanted the hole to close because you don't want the recurrence of the detachment. So remove all the membranes, reattach, and go back to doing the old treatment of what we used to do in a macular hole, also detachment, that is laser photocoagulation to the hole. So in the sense, half burn in, half burn out. So very small area of retina will destroy, because this hole is never going to close. So all we want is not allow the retina to redetach again. So that was one option, do laser photocoagulation, half burn in the bad RP, half burn at the edge of the thing. Otherwise, you can put the amniotic right over the thing and then probably put a drop of glue and then leave it there. So what we don't want is the posterior retina to detach. So that could have been done as well. Of course, like what you have done works quite well, but I don't have experience of putting this bigger graft. The last I saw this bigger graft was, I think, Barbara Peroni had put in some thing where the subretinal space she has put after removing the CNVM, if I remember right.
Yeah, but I didn't expect this to crumple up and go to the side on its own. Probably the proliferative forces are still intact.
It usually doesn't happen that way. Of course, like people have put it under the retina, not on the surface of the retina. I don't know if somebody has seen, I think she's put it in some of the groups, I think.
Epiretinal. Most of the times it's epiretinal. Yeah, a large sheet of amniotic membrane graft, almost 5 millimeters, they place it epiretinal.
What are the purpose of that?
For the chronic macular holes which are not responding to treatment.
Okay.
So do you think really it helps in this situation because you're putting a large...
I didn't expect this to crumple up actually to so much extent, but I thought that there is a chance the macular hole is large and the patient already had a PVR. So if by chance there is a recurrence of PVR, I thought this amniotic membrane graft should be larger so that even if it contracts, it will still plug the macular hole. That was my idea of putting a larger graft.
But, especially the peripheral, very atrophic retina, I would be very hesitant to work on this because, I mean, you were daring that the peeling of the membrane was really good. But in this, especially in those places where there's so much of extensive, was he overnight patient?
No.
Okay.
He has other diabetic retinopathy again. He's been operated for vitreous hemorrhage, for diabetic vitreous hemorrhage.
Okay.
Thank you.
Thank you.
And did you, the surface of the membrane, is a freshly harvested amniotic or a dried one?
The cryopreserved. Cryopreserved.
Okay,
yeah.
And that probably the surface doesn't matter, right?
Yeah, surface doesn't matter.
Because otherwise, like maybe that would have explained why it crumpled. If it was a fresh membrane which had used, I don't understand why it crumpled.
So it was actually a tug of war between the normal retina and your amniotic membrane, probably. So we'll move on to our next presenter, Dr. Himadri Chaudhary. Please.
At the very outset, I'd like to thank Dr. Rupak for inviting me. I'll be talking about a case of culture-negative presumed fungal endophthalmitis. So this is how the patient presented to me. A little bit about the history. The patient was a 68-year-old male. He had a visual acuity of PL only, and the left eye had 660 vision. He had undergone a pterygium excision with conjunctival autograft and a AMG for double-headed pterygium around 6 weeks back elsewhere. According to the treating physician, he developed microbial keratitis after 1 month and then was put on topical natamycin and voriconazole along with oral voriconazole. And he had an initial good response, but apparently it worsened afterwards. So this was the other eye of the patient. I did a B scan and I could find some membranous echos. So I labeled it as endophthalmitis and moved on to do a pars plana vitrectomy. So visibility was extremely poor, even though I had cleaned up the anterior chamber. However, I could see the disc, and after a core vitrectomy, I went ahead and injected voriconazole Ampho-B along with Vanco and imipenem. Initially, the patient seemed to respond, but within next 3 days, the patient had worsened, along with increase in hypopia and increase in corneal infiltrate. So I thought it looked like a fungal end-off to me. I had had some experience in treating fungal end-off post-pterygium surgery, where we treated these patients very aggressively with injections of voriconazole and Ampho-B almost every alternate day, and for a long time till the response was noted. So we went ahead and started doing this aggressive regimen, but after 5 injections every 2 to 3 days, it was not responding at all. And by this time, the patient, along with his attendants, told me that just get rid of the eye. I do not have vision. I am not anyways seeing anything. At every step, we did a AC tap, we went for a culture. We do not have access to PCR, so that is something we could not do. And the patient did not have the resources to go to a higher center. So I did not want to give up, and I looked into literature and found that people have had success with intravitreal povidone iodine. But it was only one paper by the same author. He had two papers similar to that. So the preparation is fairly straightforward. From the 5% commercially available povidone iodine drops, you take 0.1 ml, mix it with 0.3 ml of normal saline or distilled water for injection, and then you discard the 0.3 and keep only 0.1. So that gives you 1.25% in 1.1 ml of fluid. So we went ahead and did an injection. And 3 days later, I could see some response. The corneal lesions were looking better. The hypopyon had reduced. We went ahead with another injection after 72 hours. And the patient's end-off got resolved completely. But however, we were left with not a very good-looking cornea. Patient still maintains hand motions movement, and we have stopped all voriconazole along with other medications. So this is how the patient had presented with. This is how, after the initial pars plana vitrectomy and injection of vanco voriconazole, and this is after the intravitreal povidone iodine. The echoes had fairly cleared off. So to conclude, managing culture negative end-off is a challenge. Probably the fungistatic nature of drugs may hinder the resolution of fungal end-off, and I don't know whether the panel has any experience with intravitreal povidone iodine. Thank you.
The vitreous appeared very clear. Was it like in the beginning when you did the vitrectomy?
Yes, only exudates were mostly anteriorly present, and the retina and all look very clear. Like normally we see in fungal end-off, mostly the retina has no lesions. It looks extremely good. So it was like my hunch was that it was probably a fungal end-off.
So the corneal lesions had subsided?
Had subsided completely, yes. There's just opacity now.
So what do you plan to do? PKP?
We are waiting for some time. Now I want to wait for some time before I go for a repeat triple procedure or something.
I have no experience with povidone iodine. I don't know, Mahesh.
Yeah, we have used it actually, and in refractory endophthalmitis, not as a primary treatment. And there are multiple ways of using it. One is like to inject it about 3.5 hours before or 4 hours before the vitrectomy, and then go ahead with the vitrectomy. Mm-hmm. Second is like one thing is like it kind of degrades faster, so you have to prepare it freshly 15 minutes before we give it, and we can put it into the infusion also. So when you do the vitrectomy, you can. My colleague Divyanshi puts it in the vitrectomy and uses that fluid to do the vitrectomy. That's the second one. And at the end of it, of course, you can leave povidone iodine like what you have done as well. So we don't use it as a primary treatment, but in refractive endophthalmitis, which is not responding to anything, we use it. And there are not everybody who believes it, because povidone acts by contact. So contact with the organism by denaturing the cell membrane. So that may not happen all the time is what some people think. And in this patient, like Dr. Kim mentioned, the vitreous was clear, so I was wondering if there was a need for a vitrectomy. A corneal scraping may have given us...
We tried that, but we couldn't get any fungal elements.
Okay. So probably like when nothing works, you would have to try something else, and then we would have also tried povidone iodine.
Yeah, I think Dr. Sangeet also have the similar kind of experience of using, diluted povidone iodine. Why don't you share your experience?
So I have used it along with vitrectomy solution, 0.025% in the vitrectomy solution. Just mix 2.5 ml of the normal povidone iodine we get into 500 milliliters of ringolactate. And I found it, we compared actually 10 cases of endophthalmitis without povidone iodine and 10 with, and we found a very positive result when we used it. So now I'm routinely using in all endophthalmitis cases if I'm doing a vitrectomy.
But this is not for...
endophthalmitis.
Yes. When I'm using a vitrectomy surgery, along with
vitrectomy, the infusion fluid contains povidone.
Yes, sir.
But initially, the cases were included fungal endophthalmitis as well? No. Do you have separate experience about the fungal?
Not a separate experience. All cases initially when we did a trial, we included only the cases who were not responding to other modalities of treatment.
Works in fungal also.
Yeah. Okay. So, good take-home message for all of us. Dr. Sangeet, if you can just present the next. And all those cases, you just do a vitreous lavage and leave it, sir, or you need to. He has given intravitreal injection.
Correct. You can do that as well. But if you're doing a vitrectomy, like 0.025% is the fluid is what is the percentage of povidone going inside. So you can inject 2.5 ml in a 500 ml of bottle of the infusion, the ringalactone solution, and then go ahead with the vitrectomy.
What literature support you have about the retinal toxins?
I just found one paper by the same author. He had two papers. One where he had done the infusion with povidone and one where he had injected intravitreal. And he found out that the ERG studies before and after were normal and there was no toxic effect.
Yeah, I also did that ERG study, sir, and the corneal endothelial cell count, and both were comparable in both the groups.
There are animal studies as well as like there are papers to say that it's not toxic.
Why don't we use it more often?
As I mentioned, we still need something for because like I'm not using it all the time. That's one. Because like povidone in solution itself can be contaminated. That's also there. So that has been a cause for cluster endophthalmitis also been shown. So when we have antibiotics, we use it. That's all. So refractory cases, yes, I would use it. Like probably Sangeet is beginning to use it for all the cases. So
yes, please.
Good evening, everyone. Actually, this is something because I was told to present some innovations. So this is 3 minutes talk, 3 innovations for ocular fluid sampling. Can I have the video, please?
Conventional AC tap using tuberculin syringe often needs an assistant to hold the eye, while the surgeon withdraws the fluid using both hands. Also, sample collected is not sufficient. We describe a new homemade device for aqueous tap. The 2 cc syringe is cut at its back end and a rubber suction cap is attached to it. 26 gauge needle is then mounted on the syringe. Small hole in the rubber cap acts as a safety valve. Vacuum is created by pressing the rubber cap after covering the hole with finger. Aspiration is done when the pressure over the cap is slowly reduced as shown in this demo. Vacuum is created by pressing the rubber cap before the needle enters the eye. Once the needle is in AC, the pressure over rubber cap is reduced and the aqueous gets collected in the syringe. The obtained sample can then be inoculated directly over culture media or sent to lab after covering the needle. The conventional method of vitreous tap causes pull on the vitreous, resulting unsafe vitreoretinal traction in already inflamed retina and may lead to retinal detachment. We present an innovative method of vitreous tap which is safer, easier and does not cause traction. 3-way cannula is connected to the vitrectomy aspiration tubing and the third extra port is kept closed. 25 or 27 gauge sclerotomy is made superatemporally 4 mm from limbus and cannula is inserted. Vitrectomy cutter is used to cut and aspirate the vitreous till the eye becomes hypotenuse. This is indicated by inward dipping of cornea. As we cut and aspirate, the vitreous collects in the aspiration tubing. Intravitreal injection of antibiotics is then given through the same cannula. This also helps in rebuilding the intraocular pressure back to normal. Cannula is removed and sutureless closure of sclerotomy is done. Syringe is connected to the third extra port of 3-way cannula and vitreous fluid in the tubing is then actively sucked into the syringe by opening the port. The obtained sample is then sent for microbiology. Though the bag in which the fluid collects can be sent to lab for microbiology, but many times we reuse the same bag either for multiple procedures or on multiple days. This compromises the quality and sterility of fluid. We present an innovative hack to collect the vitrectomy fluid for adequate sample. An IV tubing is placed in a pre-sterilized ringer lactate bottle. The plastic connector at the other end is removed and it is then connected to the vitrectomy machine. Thus, the bottle acts as the collection bag. The vitrectomy fluid collects into the bottle during the procedure. The whole bottle can then be sent to lab for microbiology.
Thank you, sir.
Yeah, innovative way of thinking things. Any comment?
Very nice, Sangeet. What is expected out of you? The last one, why is there a air vent syringe, air vent needle?
Pardon, sir?
In the last bottle,
yeah.
why you have an air vent needle?
Because we need an outlet. Then only the water will. Then only the fluid goes inside the bottle.
No, it's connected here, but where is the suction generated from in the bottle? Where is the suction generated in the bottle? Are you doing something like what you have in the GA suction machine?
So it's the bottle is again connected to the vitrectomy machine. When you remove the bag and you connect the bottle.
But I saw only one needle going inside, right?
So there's one needle going inside, and the infusion, the pump that we use, the IV thing, or IV tubing, which we use, is connected to the other port in the bottle. The other side of the IV tubing is then connected to the vitrectomy machine. You remove the bag, and in that particular...
No, that I understood.
Yes, sir.
But from the vitreous cutter, how is it going inside?
So from the vitreous cutter, it goes into the cassette, and then through the cassette, as it has to be collected in the bag, instead of getting collected in the bag, the fluid gets collected in the bottle.
No, but so the thing is going into the cassette and then going here.
Yes, sir.
So instead of that, what I was trying to say is like between the cutter and the machine,
you can directly connect.
Why don't you put the bottle and put one going inside, one coming out this side? It can be a smaller bottle. The 50 ml bottle, the 50 ml infusion bottle, which we use for pediatric cases.
Yes, sir.
You understand what I'm saying? It's like the GA suction bottle, like that. So from the cutter it comes, goes inside on one port, and from the other port it goes to the cassette.
Sir, in that situation, cassette
That's what
fluid...
suction will build up, no, sir, because this is an enclosed, you're putting a bottle in between this and this, that's all. And it's a watertight one.
So bottle is kept at the last.
No. I'm saying bottle is here in between the cutter and the machine.
Okay.
So that way, like your cassette will not also get contaminated. Everything will go directly into the bottle.
I'm not sure if you'll still build the suction with that process.
No, the air inside the bottle has to go out, no, sir. Once that is goes out, I think there should be suction. Maybe not as effective as the regular direct suction, but and we have to try it out and see. Probably you may have to increase the suction of the machine to see if it works. So the smaller the bottle, I think it should be working effectively.
Yeah, thank you. Sir.
But instead of what Mahesh is suggesting, can you not put a cylinder on the tube where the cylinder collects?
That's right. Instead of the cylinder, I'm saying the bottle. Yeah, that's what. But actually, what I do in these cases is I usually connect a small bit of the tubing. That tubing you disconnected, right?
Yes,
from the cutter to the connector.
Yes.
Reverse it. And the other side is like connected to a 10cc syringe, and the whole thing is aspirated by the assistant.
Okay.
So directly goes into the syringe, so there is no thing. So I didn't know that like you have a manpower shortage in that like you need
So again, then it will be a manual suction. So this is an automated one.
Yeah, manual suction, it's okay. That's like a 10cc syringe, ask them to generate. So that's how I usually do a vitreous biopsy for a lymphoma case. So where the assistant actually aspirates the whole vitreous in a 10cc syringe, so directly with a short tubing, so that the whole thing comes there, and then that's how I do it.
Yeah, thank you. But it is always stimulates the brain. Next is Dr. Unnikrishnan Nair, please.
Yeah, so every year Retinnova session, everybody presents their innovations and I present my complications. So I was getting my complication ready and he changed the name to Retinnova. So I had to borrow one of these, one of my, done in our institute from
merits and demerits of linear inner retinal layer fenestration for optic disc pit with maculopathy. This 30-year-old gentleman living in United Kingdom visited us with complaints of sudden onset of defective vision in his right eye. Right eye evaluation showed a best corrected visual acuity of 624 N36 and fundus evaluation showed an optic disc pit with 4 disc diameter of serous detachment of the macula. Although pars plana vitrectomy is considered the gold standard for the treatment of optic disc pit, OCT showed an impending macular hole and multi-layered fluid in the macula as well as areas inferior to it. we decided to do a vitrectomy with ILM sealing of the pit and inner retinal fenestrations away from the macula. Special attention was given to release the vitreous over the area of pit. For the fear of inducing a macular hole, peripapillary ILM was peeled in a petaloid fashion and inverted onto the surface of the disc with the help of PFCL bubble. A 23 gauge needle tip was used to make multiple linear fenestrations, following which a fluid air exchange was performed and no post-operative position was advised. Post-operatively, there was more than 50% reduction in the central foveal thickness and a quick resolution of fluid around the area where the retinal fenestration was done. First described by Spade et al., this technique is effective in the treatment of optic disc maculopathy, and various studies have reported fluid resolution in about 95% of the cases. Most of the studies have performed fenestration just adjacent to the optic disc pit. This could cause a visual field defect as papillofoveal fibers are densely packed in this area. Macular field in our case showed complete resolution of scotoma with normal fields. However, mid-peripheral field showed scotoma corresponding to the area of inner retinal layer fenestration, proving that fenestration induces field defects. Our technique could be performed over the previously described technique as it spares the papillofoveal fibers, thereby better preserving central field of vision. Advantages of this technique is that it facilitates faster resolution of fluid and avoids macular field defects. So to conclude, linear inner retinal layer fenestration is an effective technique for managing optic disc pit maculopathy. It may be performed within the arcade, sparing the papillofoveal bundle fibers with similar results. This technique could be done as a primary procedure or in cases where there is recurrence of the maculopathy associated with optic disc pit. Thank you.
Thank you. So I'll ask myself the first question. Why was it the inner fenestrations or was it the plugging of the pit by the ILM that caused the difference? So one particular thing in this patient we saw is the rapid resolution of the skytic element. The skytic element sometimes takes a long time. The SRF takes an even longer time to come down. But in this case, that would be the slight difference that we see. I have patients where both these elements have remained for nearly 1 year before going down. And here in about 2 to 3 weeks, we see there is a regress of the fluid. Probably we're letting it out also. It could be the fact.
So the fenestration description by Dr. Spade, which has been described that this is the fluid collected there, is actually not that fluid is coming out. It is a vitreous fluid, water which is seeps in and making it diluted. So the absorption becomes much faster. So that's how it has been described. And as because there is a slit in the ILM, so that helps the retina to settle down faster because of the taut ILM not there. So any other comment for this?
No, have you compared this plugging versus adding the fenestration to it?
No, not in a study, but in most of our cases, we find that there is quite a lot of this. Is surprisingly 2 weeks, and there's a tremendous change, and that is it could be a case-to-case thing, and virtually we're talking about anecdotal evidence here, but not directly compared in a large study. No.
Yeah, I think this will definitely add to it, but I think plugging does take care of the solution.
So just a question is, what are the factors actually? It is the chronicity of the disease and the stagnation of the fluid there which is causing slower absorption, or the sciatic cavity forms which is leading to the chronicity? So if that is the cause, then what his hypothesis is absolutely correct, because by fenestrations the retinoschitic cavities are actually destroyed, so it becomes much faster, flatter.
There are many unknowns actually as far as the optic disc pit maculopathy is concerned. I have Meenakshi presented somewhere else. Like there are two patients. One was a young child. So in that child, I stuff a fairly large piece of sclera. Yeah. Then you can see it getting pushed out. Then I push it again, put another piece of sclera. Again, you can see both getting pushed out during surgery, indicating that it's actually the CSF which is coming out. This was not vitreous fluid pushing it out. So there are both components. I think in some patients, probably an elderly patient, it's just a vitreous fluid which is going through the optic disc pit and going into the retina. But in a younger patient, probably there is a component of CSF. You can literally see it being pushed out, and that cannot be because of vitreous. And this is as I'm doing a vitrectomy. So there are two components. So probably in a young patient who has acutely developed it, it's probably the CSF which is causing it. And that patient as acutely developed, as acutely it may regress as well. But in this patient, probably it was long-standing, and then chronicity and making these linear lacerations made it go away. Possible. But like another thing is like Uni himself showed, here the fluid was extending beyond the arcade and more nasally. So it was possible to make these radial fenestrations. But like when it is within the arcade, macula. How are we? They did make a mention that like sparing the papillofoveal bundle, you can make those. But I don't know if you can make those linear circumferential fenestrations that easily or not. We will never know. As Dr. Kim was mentioning, whether you will be able to do a case control trial or for a very specific disease like this and then show, it's difficult. But like Dr. Naresh has shown the plugging comparative and then showed that. So if you are able to collect so many cases and do this technique, and then probably you will be able to show that. Until that, whatever we say will be conjecture.
Thank you. I will request Dr. Debdulal for present his case.
I would like to thank Rupak for this kind of opportunity. I'll be presenting our technique of closing macular holes which are large. So this is something that we have published in the recent past, and so basically I have no financial interest in this. As we all know that recently, moving away from the old classification of small, medium and large holes, holes that are larger than 650 microns have been classified as the really large ones, and primarily because if you have holes lesser than 650 microns, the base diameter, that is, you have a high success rate. But when it becomes, the base diameter becomes more than 650 microns, the success rate drops drastically. And if you look at the Indian context, most holes are large and they present late too. So if you look at the core principles of macular hole surgery, so you have to relieve traction, you have to make the retina compliant and enable closure and prevent fluid from entering the hole. So if this is some kind of Indian jugaad that we have arranged, we massage the retina from around the macular hole after doing the ILM peeling, and the hole becomes a slit. And this massaging is done with a silicone tip 25 gauge cannula, routine 25 gauge cannula. And once it becomes a slit, just drain off the fluid from the macular hole. This fluid is usually very, very viscous, and you have to have some time, to sort of drain this off. And I'll just show a video, and this is something that we've been doing for a while. So initial steps are very similar to what we routinely do. Obviously, we do a complete vitrectomy, induce PVD, and ensure that there's good vitrectomy that is initially done. And then, of course, stain the ILM with BBG, take off the excess BBG, and then ILM peeling, routine ILM peeling is done. In larger holes, it is a good idea to do a slightly larger peel, and very important to remove the ILM from around the edges of the hole. and just enlarging a little bit the ILM peel, area of ILM peel. And once this is done, take your silicone-taped cannula and just massage the retina. So there have been lots of reports of inducing a retinal detachment to sort of make the retina compliant. One would be surprised to see how compliant the retina is actually. And you can really massage the retina and make the hole turn into a small slit. So you have to be gentle. It really doesn't, cause any sort of bleeding or anything of that sort. And I haven't had any tears for long. Many of us are using this. And once you are, you have sufficiently sort of made the, apposition, you can just, drain off the fluid from the, macular hole, and it closes the hole. So what actually happens is, you have, within a week, you have closure of the hole, any size. We've seen even 1400, 1500 micron holes close. And actually what happens is drainage of the fluid and bringing together of the whole edges kickstarts the hole closure. And you can find this at 1 week, and you can close really large holes. And just to sort of mention that the second publication, the macular hole base diameter was 1162 microns, the mean, and the initial publication was 835 microns. So we've also checked MFERG, that will be coming up in a subsequent publication, hopefully, if it gets published, and also checked 24-2 and 10-2. We didn't really find much difference with a normal inverted flap that we do. Thank you.
I've heard this from an Egyptian group many years back, I think, probably 10 years, 12 years back. I have done this for traumatic macular holes, which are very, very big. So it's a nice technique, except that you don't know how much of damage you're doing by stroking the retina. So when you can avoid doing that, then and still close the hole, then probably you can take that route. But very large holes sometimes you will have the edges of the hole rolled inside, underneath, so undermined. So those I have literally dissected them out and then brought them in. And there you're not worried about how healthy the retina is going to be. You just want closure of the retina. In that situation, one other thing you can do is to actually gentle suction. You can use the flute with a soft tip over the hole, and actually the margins of the hole get sucked into the flute and then close the hole also. So you can literally see with this technique the hole closing on the table itself. Downside is how much of retinal damage you have created, we don't know, number one. Second one is when you aspirate the fluid, there's a possibility of the underlying RP also getting damaged. So these are two possibilities which you have to keep in mind. Of course, in skilled hands like Debdulal's, it works everything. But then if novice surgeon wants to do it, go through the normal steps of macular hole surgery and then do it. Don't do this as the first technique.
No, yes. The Debulal, do you use the soft tip cannula to use it? Because every time, I used to do this earlier with the Thanos diamond industrial, it does so much of damage to the nerve fiber layer when you stroke. Every stroke that you do on the retina, I think that we stopped doing it for that reason.
So Thanos has actually been described in some of the recurrent macular holes, this technique, but they have not aspirated the fluid, number one. And actually the silicone-tipped cannula, especially if it's an old one, slightly used one, which we reuse normally in our cases. So in those, there is absolutely no the Thanos thing, the damage it causes is not seen with the silicone-tipped cannula, especially the older ones.
Yes, a continuation of what you told with the taking out with the soft tip cannula, taking out the fluid, which is the residual fluid in the macular hole area. So again, if you do it and to repeat it in multiple times, then I wait for maybe another 1 minute or something like that. Again, the fluid comes and then get redeposited, and then slowly again macula goes back. So 2-3 times, if you do it, it really becomes smaller and it remains small at the end of the surgery.
Correct. Yeah, at the end of the surgery, it becomes smaller, but the patient, lying down, again the fluid will collect.
Yeah.
So what is more important is because earlier concept was make the retina completely dry. But now that concept is not there. So what you do is ask the patient, as soon as he gets up from the table, maintain a prone position. So as he's going in a wheelchair itself, he keeps his head down like this. So start maintaining the prone position from the OT. That's supposed to be much more helpful. So instead of complete drying of the retina, and drying of the retina has been associated to show those nerve fiber defects as well, and subsequently. So there's no need to dry it so
completely.
much.
Yeah, we'll invite our last speaker and showstopper, Dr. Shubhendu Boral.
You have to walk like a showstopper.
He is indeed.
Audio. Basically, I tried this technique combined ILM peeling and subretinal BSS injection in cases of congenital falciform fold, and that gave me the result in few of my initial cases. This is one of the very first 5 cases. Audio, please.
We have no financial interest to discuss. Falciform folds are congenital tractional retinal folds due to strong tractional retinal forces and hyperextensibility of retina. This results in temporal dragging of macula and vision loss. Occasionally, it is associated with familial exudative vitreoretinopathy. Even the hardcore surgeons are often reluctant to touch these cases. This video demonstrates a novel innovative surgical technique to remove both preretinal and subretinal adhesions to unfold these folds. 43-year-old male presented with dimness of vision in right eye since childhood. In left eye, it was for last 1 month. In right eye, there was a falciform-shaped fold extending from the disc towards temporal periphery with temporal dragging of macula and a small fundal coloboma just temporal to the optic disc. In left eye, there was fovea on temporal retinal detachment. The plan of surgery in right eye was vitrectomy with ILM peeling with injection of balanced salt solution subretinally and sulfur hexafluoride gas tamponade. In left eye, vitreoretinal surgery with silicone oil tamponade to settle retinal detachment. 25-gauge vitrectomy was done in right eye with removal of all preretinal vitreous bands and fractions. ILM was stained with brilliant blue G dye and peeled in a patchy manner as it was very stickily adhered to the underlying retina. ILM peeling was also carried out over and around the falciform fold. Diamond-dusted membrane scraper was used to do gentle rubbing over the wrinkled macula to flatten the fold. Then a 38-gauge polytip needle attached with a BFC syringe filled with balanced salt solution was used to inject BSS subretinally. It formed blebs at multiple locations around the falciform fold. The subretinal BSS would stretch the subretinal space to remove subretinal adhesions in this long-standing fold. Finally, presence of any peripheral adhesions was checked again and air fluid exchange was completed. After 3 months of surgery, the fold at the macular area was narrowed down and almost flattened. Vision improved to 20/80. So to unfold the falciform fold, things we should remember. There are both long-standing pre- and subretinal adhesions. Preretinal adhesions can be released by vitrectomy, adhesion removal, ILM peeling as well as mechanical stretching by Thanos scraper or Finney flex loop. For subretinal adhesions, inducing subretinal stretching by injecting BSS subretinally, but it should be done away from fovea to avoid macular hole formation. Thank you. We have no financial
Our 5 case series has been published in the journal Retina as surgical technique. This one. congenital retinal folds.
This has been described for the post-operative retinal reattachment if there is macular puckering. Especially those cases has been described along with this. Sir, your comment, anything?
Spendu, I just wanted to know why the ILM peeling, how does it help in this? Because the traction is more in the periphery, which is what started,
yes, sir.
right?
Yes.
So does it still hold good in removing this?
Basically, to unfold the whole fold, it is very difficult to do all the procedures. You have to do the temporal retinectomy, then just detach the retina, then again unfold it again, then do the laser, doing laser, just treat it as a GRT-like case. Then you can only do the unfolding. But I am just unfolding the falciform fold component at the macula. That's why the vision is improved.
But still the peripheral traction that is existing there, how do you get it released?
Peripheral traction, it is, in my case series, as the vitreous is not there and the surrounding vitreous traction is not there, so peripheral traction is not creating problem at the macula. And basically in most of the situations, the traction is actually unknown. It may be pre-retinal, it may be subretinal. So I have removed both. Subretinal BSS injection has been described in the previous literature. Nobody described this combined technique to unfold the falciform fold at the macula.
Yeah, as usual, very nicely done, Dr. Subendu. Very beautiful technique. Did he have diplopia after the surgery?
Diplopia, no, sir. Other eye has detachment because that eye also very poor vision. Now in both eyes, patient has got the ambulatory vision.
Oh, the other eye also has detachment.
Detachment, yes.
Because I thought like other eye was normal. Because if he has other eye normal, this side with the macular ectopia, then his vision being improved.
Yes.
So he would have complained of diplopia.
Now in both eye, patient is having 6/36 vision.
Okay, fine. I have not done any of these because usually I've tried a clear lubrication in patients, younger children. So where there is a fibrous tissue in the periphery. So if you want to relieve that, then you have to do a retinectomy, which is a misery if you were to do in a child. So in that situation, I have done a scleral lubrication. Instead of lengthening the retina, shorten the sclera, so that the anteroposterior traction is relieved, and then the fold opens up to some extent. So this I have done in zone 3 ROP, which is untreated, which is formed of fibrous tissue and a falciform fold. But of course, the falciform fold should not be so elevated, like what you said, should be a shallow fold, in which case like this opens up. But if it is elevated like a sharp knife, then it doesn't open up. So that's something which I have done.
Yeah. Thank you. If there is no other, I think banquet is waiting for you. So thank you all. Thank you, really, really. At the end of the day, so many people are sitting here. That makes us, inspires us always for the next sessions. Thank you for all our mentors and all the innovators. Thank you once again.